Welcome to the deep dive. Today we're focusing on negative pressure wound therapy, NPWT.
That's right.
Think of it as applying controlled suction to a sealed wound.
Pretty much, yeah. A closed system under subatmospheric pressure.
And our goal today is really to clarify how it works, how you apply it, and crucially, the indications and contraindications in surgical practice. Really key stuff for your board exams.
Absolutely. It seems straightforward, but the why it works is important. Let's start with the fluid mechanics.
Okay.
So the negative pressure, it helps pull out excess interstitial fluid.
Right, the edema.
Exactly. And removing that fluid is good because too much of it hinders microcirculation.
Impedes oxygen and nutrient delivery.
Precisely. And waste removal, too. Plus, you're potentially removing local toxins building up in that fluid. So it cleans up the local environment,
Makes sense. Creates a better milieu for healing.
Hmm.
But it's not just about fluid removal, is it? There's a mechanical side, too.
Yes, the mechanical stress aspect. We talk about a tension stress effect stimulating cellular proliferation.
Okay, break that down. Macro strain.
So macrostrain is what you can sort of see. The dressing collapses under the pressure, distributing that pressure evenly. And importantly, it pulls the wound edges inward, retracts them. It's a direct physical force.
Aiding closure on a larger scale.
Ah,
And microstrain, that's the smaller picture.
yeah, exactly. Microstrain is at the cellular level. The tissue gets drawn into the pores of the dressing, like the foam.
Sure.
This creates tiny microscopic deformations in the tissue structure.
And that stimulates?
Angiogenesis, new blood vessel formation, and just general granulation tissue growth. It's stimulation on a micro level.
Got it. So working from the big picture down to the cellular level and bacterial load reduction that's often mentioned.
It is. NPWT does seem to decrease bacterial burden. The exact mechanisms are debated, but it's likely a combination of removing exudate containing bacteria and their byproducts, and maybe improving local immune function.
Okay, so we have a grasp of the mechanisms. Now let's talk application. How do we actually do it?
Well, first step is always proper wound prep, debridement, cleansing, the usual.
Sure.
Then you might place a non-adherent contact layer directly onto the wound bed, things like Adaptic or Zeroform.
And would you definitely use that?
Particularly important over delicate structures, grafts, tendons, vessels, to prevent adherence or damage from the foam itself.
Right. Then comes the main contact dressing. Let's talk foam. Polyurethane, the black foam.
Yep, that's the classic one. It's hydrophobic, meaning it doesn't absorb water itself. Its key feature is the pore size, around 400-600 microns.
And why is that size important?
That size range seems optimal for stimulating that microstrain effect we talked about, promoting robust granulation tissue. Most of the clinical evidence for NPWT is based on this type of foam.
Okay. And the alternative?
Eh.
Polyvinyl alcohol, the white foam.
Right, the white foam. This one is hydrophilic, so it holds moisture, and it has much smaller, denser pores, 60 to 270 microns.
Less granulation stimulus.
Potentially, yes. So you might use it when you want less aggressive granulation tissue formation, or perhaps over those delicate structures, sometimes even without a separate non-adherent layer.
Interesting. And silver sponges.
Silver-coated versions, usually of the black foam. The silver provides an antimicrobial effect. Good for contaminated wounds, helps reduce odor, likely by killing bacteria.
We'll watch out for.
Silver allergy, absolute contraindication there.
Okay. What about just using simple gauze?
Gauze is an option. It's often easier to conform to complex wound shapes, no-shape memory. Some argue it might be less painful on removal compared to foam where tissue can ingrow.
Any others? Honeycomb textiles?
They exist, yes. Another interface option, but maybe less commonly used or studied compared to foam and gauze.
So with these choices foam, gauze is one clearly superior.
It's interesting. In vivo studies haven't shown significant differences in things like blood flow changes, microdeformation, or pressure transmission between them. Yeah. And clinically, observed differences in wound size reduction or healing time aren't dramatically different in many situations. Maybe foam is slightly better for nice uniform wounds needing contraction. Gauze may be easier for shallow or complex shapes.
And for skin grafts?
General recommendation is definitely a non-adherent interface layer first, regardless of whether you put foam or gauze over that. Protect the graft.
Makes sense. So contact layer chosen, next step.
Sealing the deal. You need an airtight system. So you apply adhesive drapes over the dressing and extending onto the surrounding healthy skin. That seal is critical.
Right, otherwise you lose the negative pressure. Then apply the suction, continuous or intermittent.
Continuous is most common, standard practice. There's some suggestion intermittent pressure cycling might stimulate granulation tissue a bit faster, but continuous is the default.
And the pressure level.
Typically in the range of -50 to 125 millimeters of mercury. Studies suggest maximal blood flow increase happens around -125 millimeter Hg.
Okay. Do these machines have safety features?
Yes, many modern systems have alarms. They can detect leaks if the canister is full, sometimes even high levels of bleeding. Adds a layer of safety.
Good. Dressing change frequency.
Standard for a non-infected wound is usually at least 3 times a week, say Monday, Wednesday, Friday.
And if it's infected?
More often. Daily, sometimes even more frequently initially, often guided by the amount of exudate and clinical appearance, requires close monitoring.
Can that frequency decrease?
Yes. Once a wound is looking clean, granulating well, stable, you might transition to maybe twice weekly changes.
Let's quickly touch on fluid installation. That's sometimes combined.
Yes, NPWTI, the I for installation. You're delivering a solution, often saline, sometimes with antiseptics or antibiotics, into the wound bed periodically.
How does that work with the suction?
Usually intermittent suction. The fluid dwells for a set time while suction is off, then suction resumes to remove the fluid and exudate. Or sometimes continuous, instilling at one end, suctioning at the other.
Potential benefit for infection control.
That's the idea. Direct antimicrobial delivery, mechanical cleansing. Still evolving evidence, but used in selected cases.
Okay, that covers application well. Now let's pivot to indications and contraindications.
Yeah.
When should we use NPWT?
It's got a pretty broad range, useful for many wound types. Chronic wounds like ulcers, diabetic, pressure, venous. Also acute and traumatic wounds, dehisced surgical wounds, partial thickness burns, and as an adjunct for flaps and grafts.
Let's focus on acute wounds first. Big soft tissue injuries, contaminated wounds.
Right. For those, the prerequisites are key. Thorough surgical debridement of all non-viable tissue. Get rid of foreign bodies, make sure hemostasis is achieved. And ideally, if there are vital structures, exposed vessels, nerves, bowel, you'd want to cover those with local tissue if possible before putting NPWT on.
And if contamination or sepsis is a concern?
Then you're looking at more frequent dressing changes, maybe every 24 hours initially, alongside appropriate systemic antibiotics and possibly repeat debridement.
Okay.
And chronic wounds, pressure ulcers, venous ulcers. Again, debridement is paramount. I've got to remove that non-viable stuff. NPWT can then help kind of kickstart a stalled chronic wound, almost converting it into a more acute state that responds better.
Makes sense. Now, the critical part for exams, contraindications. When should you absolutely not use NPWT?
Okay, key ones: exposed blood vessels, nerves, or organs in the wound base. Huge risk of erosion or hemorrhage.
Right.
Malignancy in the wound. You don't want to potentially stimulate tumor growth or spread.
Untreated osteomyelitis.
Correct. Need to manage the bone infection first. NPWT isn't a primary treatment for osteo.
Non-enteric or unexplored fistulas.
Yes. You need to know where the fistula goes. NPWT could worsen things if applied incorrectly.
Fresh anastomotic sites, like bowel surgery.
Definitely avoid direct application, risk of disruption.
And straightforward necrotic tissue, dry Escher.
Yeah, NPWT doesn't work through thick, dry Escher. It needs to be debrided first so the pressure can reach the viable wound bed.
Are there any gray areas? Can you ever cautiously use it near exposed structures?
Very cautiously, on a case-by-case basis. Maybe using the white foam or extra non-adherent layers as protection with close monitoring, but the default is avoidance, high risk.
Understood. So what are our main treatment goals when we decide to use NPWT?
Several goals: managing exudate, protecting the wound from external contamination or drying out, preparing the wound bed, stimulating granulation, reducing size and complexity, maybe reducing bacterial load.
Patient comfort too.
Yes, often fewer dressing changes means less pain, potentially better mobility. Managing exudate and odor improves quality of life.
And cost.
Potentially reduces overall costs by speeding up time to closure or surgery, preventing complications, maybe allowing outpatient management or earlier discharge. Reduces nursing time for changes.
Improving outcomes overall, perhaps splinting the wound.
Yes, can help stabilize the wound area and potentially prevent certain postoperative complications like seroma or hematoma in some contexts.
Okay, let's talk specific surgical scenarios relevant for boards, extremities, and orthopedic injuries.
Yeah, NPWT is really useful here. Often first line for stable, clean extremity wounds before you get to definitive reconstruction.
How does it help?
Allows for serial debridements if needed, definitely helps reduce edema, improves perfusion, keeps exposed bone moist, which is important. It's compatible with orthopedic hardware. Good for post-fasciotomy management, too.
Okay. Sternal wounds and mediastinitis post-cardiac surgery. Big problem.
Huge application. Often the primary initial treatment after adequate debridement. For more superficial sternal wound infections, it can manage drainage, splint the sternum, and sometimes lead to healing without more surgery.
And for deep infections, mediastinitis.
It's often used as a bridge. Stabilizes the chest wall, manages the infection after the patient is through the initial sepsis, maybe respiratory complications, allows things to cool down before definitive closure, often with flaps.
Any specific precautions there?
The need to be careful with the heart directly exposed. Often use a non-adherent layer, but the benefits are significant. Potentially shorter hospital stays, fewer painful changes, chest stability, allows earlier rewiring, maybe fewer flaps needed, faster clearance of infection markers, lets the surgeon control the timing of final closure.
Right. Abdominal wall defects, open abdomens.
Another major area.
Yeah.
For partial thickness defects, it can be primary treatment or a bridge. For full thickness defects, the open abdomen after damage control, compartment syndrome, severe peritonitis. NPWT is great for removing contaminants and exudate, helps decrease visceral edema, gets patients towards delayed primary closure more often, can mean less ICU time, less ventilator time.
The downside, fistulas.
Yes, there's an increased risk of enteroatmospheric fistula if the foam is directly on bowel loops, so definitely recommend using a protective contact layer between the bowel and the foam.
What about established intracutaneous fistulas?
That's an evolving area. It's sometimes used as part of the management strategy, trying to control output and protect surrounding skin. Low output fistulas might even close faster with it.
Pressure sores and perineal wounds. Difficult areas.
Very useful, especially after debridement, maybe treating underlying osteo if present. These wounds are tough to dress conventionally, high contamination risk. NPWT helps manage exudate and provides a closed environment. Getting a good seal can be the main challenge in the perineum.
Diabetic foot disease. Seems like a prime indication.
Absolutely. Strong evidence here. Facilitates healing by secondary intention, reduces wound surface area, that's level eye evidence. It's safe and generally more effective than standard dressings for healing ulcers, reducing time to closure, and potentially lowering amputation rates, often used as a bridge to definitive surgical closure or grafting, too.
Okay. Venous ulcers.
Less evidence for it as a primary treatment compared to compression, but it's a useful adjunct, especially to prepare the bed for skin grafting. Can reduce prep time, shorten overall healing time post-graft, and improve graft take.
Let's talk skin grafting specifically. How does MPWT help there?
It's a fantastic tool for bolstering skin grafts. The foam contours perfectly to the wound bed, ensuring intimate contact between the graft and the bed. Applies even pressure, minimizes shear forces and fluid collection underneath.
Especially useful for tricky areas.
Exactly. Difficult contours, large grafts. It actively pulls the graft down, promoting that initial vascular connection and osculation. If you fenestrate the graft, NPWT pulls serum or blood through the holes.
What's the typical technique?
Place a non-adherent layer over the graft, then the sponge, seal it, and apply continuous pressure, usually -75 to a -125 mmHg for about 4 to 7 days.
And the evidence supports this.
Yes, good evidence. Better wound bed prep, less graft loss, level I for split thickness grafts, shorter hospital stays, maybe even better cosmetic appearance, and improved take on chronic leg ulcers. Also beneficial for incorporating synthetic dermal matrices.
What about grafting overexposed bone, say on the skull?
Yeah, that's tough. Sometimes drilling small holes into the outer table of the bone, like the cranial diplo, to get pinpoint bleeding can encourage granulation tissue formation. Then NPWT can help nurture that granulation bed before you attempt grafting.
Right. Lastly, incisional MPWT, applying it over closed surgical incisions.
Yes, this is for closed wounds that are maybe showing early signs of poor healing, or are in high-risk locations or in high-risk patients.
What's the theory?
Thought is it helps evacuate any excess fluid or small collections under the incision, reducing skin irritation and maybe bacterial colonization. Also helps reduce edema and potentially provide some mechanical splinting.
How's it applied?
Typically, adhesive strips just lateral to the incision line, then a non-adherent layer directly over the incision, then the sponge over the non-adherent layer, avoiding direct skin contact if possible, occlusive dressing, and lower negative pressure, maybe 50 to 125 mmHg for just a few days, like 2 to 5 days post-op.
Okay, covered a lot of applications.
Right.
What about potential complications of NPWT itself?
things can go wrong. Skin edge issues are common: erythema, maceration from moisture, sometimes ulceration from pressure of the drape edge.
Mechanical failures.
Sure, loss of seal, pump malfunction. Retained sponge is a serious issue. Got to make sure all pieces are removed. Bleeding is a risk, especially if there's inadequate hemostasis or erosion into a vessel.
Infection.
Ironically, yes, if drainage is inadequate or blocked, it can theoretically lead to infection or even toxic shock syndrome, though rare, requires vigilance.
And cost effectiveness.
Yeah.
Always a consideration.
Good evidence, level 1, shows it reduces nursing time and associated costs due to fewer dressing changes. Overall costs compared to traditional dressings can be similar when you factor everything in, but patient and nursing comfort is generally improved.
Okay, let's try and summarize the absolute key points for someone revising this.
Right. Key takeaways. Intermittent pressure might enhance granulation. Max blood flow seems to be around -25 millimeter Hg.
Mhm.
Know your contraindications: inside out, exposed vessels, organs, malignancy, untreated osteo, etc. The strongest evidence supports its use in diabetic foot ulcers and over skin grafts. And remember, it's a powerful tool for optimizing both acute and chronic wounds, preparing them for definitive, often elective, reconstruction.
Excellent summary. This has been a really thorough deep dive into negative pressure wound therapy.
It's definitely a cornerstone of modern wound management.
Absolutely. And understanding these mechanisms, the applications, the absolute do-nots, it's essential for good patient care and, of course, for success in your surgical board exams.
Agreed. Keep reviewing these principles.
We definitely encourage you to look back over these topics and check out the supporting literature for a fully comprehensive grasp.